risk, but we have insufficient evidence to make a statement at this time. Now, local reactions, there's always been a debate over whether that means that there's a higher risk of a systemic. And overall, individual locals do not seem to predict systemic reactions. However, when you looked retrospectively in the severe reaction and fatality data, and David Bernstein took a look at this, frequent local reactions may indicate a higher risk of systemic reactions. So a pattern of reoccurrence perhaps is a concern. How long should you wait? I think the answer is very clear these days that it should be 30 minutes. And hopefully we're all using standardization whenever they are available. We know that not all extracts have them, but I would recommend that you do use them when available. But more than that, we need to standardize our forms. And I know that, at least in the States, our patients are always moving from one city to the next. And we have so many different methods of doing it. Every allergist has a different form, a different way of recording results, so that when you move to a new area, you're totally lost. We recommend, and all these forms are on the COMPEDIA site, that you use standardized skin testing, and Desiree and Linda Cox were primary in developing these, that you use standard treatment forms. You may want to put this on an Excel spreadsheet, which is what I did. And that as you administer the injection, you also use a standardized form. Consider a pre-injection questionnaire, asking them about their difficulties since the last injection, have they added new medications, and then consider an objective way of measuring their airway function, such as a peak flow. And this would be both before and then after, before the injection and before they leave the office. And this is just an example of one of those questionnaires. Then if you do have anaphylaxis, you need a form to make all those recordings of blood pressure and pulse and physical findings for your record. So again, have adequate staff. Whenever you're doing allergy testing, allergy injections, or special procedures, how many do you need? Well, the answer is however many you need to treat a case of severe anaphylaxis. And it's more than one person, I reassure you of that. And I always just want to remind you that anaphylaxis doesn't wait until lunch is over. And you know, when there's fewer people in the office, that's probably when something that you need help for is going to occur. Now, epinephrine, we have a big debate over to whom do you prescribe? Do you prescribe it to all patients? I personally prescribe it to all of my allergy injection patients, but not everyone agrees with that position. They say high-risk patients, but you can't always define who's high risk. Should you wait until they've had a biphasic or prolonged or delayed reaction? And the problem is, as I said, is in identifying where those high-risk groups are. It has been suggested that you give an epinephrine for anyone who has a reaction beyond 30 minutes. That makes sense. However, 1 out of 3 fatal delayed reactions had never had a prior reaction. So if you waited until that happened, it was too late. So how can we recognize and start treatment in anaphylaxis in the office setting? Now, we'll never have really good research because no one agrees to volunteer for the study. Anybody volunteer for an anaphylaxis study? So, you know, we have to rely upon consensus. We'll never have the real data that we would love to see. We do know that the more rapid the onset of the reaction, the more likely this reaction will be severe and life-threatening. And delayed reaction with delayed treatment also introduces risk. Assess the signs and symptoms of anaphylaxis. Go back to the basics, the A, B, C, the airway, the breathing, the circulation, and then we've added D, which is defibrillator. If severe anaphylaxis occurs, I want you to have a standing order in the office that the nurse administers epinephrine before you even arrive at the patient's side. It's that important. You cannot waste a single minute. CPR, remember that you need to refresh yourself on this. You activate EMS immediately for an adult. You give 5 cycles of CPR for the child, then activate. You look, feel, and listen for 5 to 10 seconds. You give 2 rescue breaths, and then you check for the carotid pulse. Decompressions in the child, 1 rescuer, 30 to 2, 2 rescuers, 15 to 2, adult is 30 to 2. And if you don't have enough staff to do all of it, the current guidelines by the American Heart Association say if you just do adequate compressions, 100 a minute, you probably can save that person without doing any airway exchange. And as I'm sure you recall from Dr. Simon's lecture earlier this week, the preferred method based on her research suggests that it should be IM. Now, we're not convinced that sub-Q fails, but the research supports an IM injection of epinephrine. And this is the data that shows a higher peak level of epinephrine when administered IM compared to sub-Q. Now, we're saying in the immunotherapy that it's preferred IM, although acceptable sub-Q. As we are now ready to come out with the anaphylaxis practice parameter, it's even a softer statement saying IM or sub-Q. And again, just to increase the debate, there's a recent article in Pediatrics just this month saying that in many children, the auto-injectors are not even deep enough to reach the IM level, and that there's evidence that perhaps sub-Q is just as good. So again, the debate goes on. And again, the Symposium had recommended IM. Now, we bring to your attention you cannot use the regular allergy injection needle for your epinephrine. You need to use a longer needle, at least an inch, if you're using a multiple dose vial. And most of us, I think, would be doing that in the office. The site preferred, again, as demonstrated in the photograph, would be the lateral thigh for administration. Certainly call for assistance, obtain your vital signs, but then position is very important. Feet up, head down. And then move your resuscitation equipment to the patient, your oxygen, your IV pole, and that Home Depot red cart. Now, this is the data for Humphreys that showed us that sitting upright has been associated with the empty ventricle syndrome, pulseless electrical activity, and increased death. In fact, 4 out of 10 of the pre-hospital death in his study was associated with just sitting up. So once you have identified anaphylaxis and started treatment, you do not want the patient sitting up until they're pretty much on the way to full recovery. And this is the position that you may find yourself in. It may be in the hallway. You may be making do with the patient on the floor. Again, a very practical point is the beds that we examine patients on. They're high. I couldn't do CPR on those. I need to have leverage. I need that patient on the floor on a hard, flat surface. So think of that. Patients really getting bad, you get them on the floor before they fall on the floor. So you have to have them in a position that you can resuscitate them. The number 2 drug is oxygen. Anytime they're hypotensive, saturations below 95, or if they needed more than one epinephrine. Face mask is recommended over nasal prongs and administers 6 to 8 liters per minute. The third drug is IV fluids. For hypertension less than 100, you will want to start fluids